Hello, everybody. I thank the organizing committee for the chairing session here. Uh, so, for our next topic, I would like to invite Dr. Anuj Maheshwari. He doesn't need much introduction. He's a very frequent comer to JPEF, and he's an important person in our RSSTI. So, I wouldn't take much of your time, sir. He has a long history of introduction. Welcome, sir. Welcome to the program. Thank you.
Thank you. Thank you. First of all, congratulations to Dr. Jyoti Dev, Sunita ji, Dr. Anita Nambiar for organizing wonderful JPEF and Arun sitting here. After this very thought-provoking discussion on the next generation lipid-lowering agents, and it's a really very interesting as well as it was very innovative also. I am taking you to diabetes care in the rural India. But it is not the step back. Many times we can think this is a step back. Once you will listen this, what I have collected the data, what I have collected the facts, you will find that those who are in the rural India, they are smarter than our urban population. And they are taking their control, they can take their control better, although they are not taking their care control better because they don't know the importance of that. But they can definitely do better. And if we can really focus on that population, we can become the good diabetes care capital of the world instead of becoming the diabetes capital of the world. So now coming to the topic. Diabetes is spreading rapidly in India. Predominantly, our country is supposed to be rural population. Our urbanization is another problem which is giving rise to this problem of the diabetes, which is upsurging very fast. And if you can see that in 1960, 82% people were living in the rural population, rural areas, now 64%. So this is the so fast urbanization and so fast regression in the rural community. Rapid urbanization has its major role. In addition to the influence of the mass media, reduced physical activity, changing dietary pattern, a lot of things are there. What we talk about the urban population, they may be applicable to the rural population, but the most important thing which is applicable to the rural population is the poor adherence to the therapy. They don't continue with the therapy. That is the biggest challenge with them. The Asian develops diabetes at younger ages with lower BMI due to the metabolically obese phenotype. In this conference, you must have talked and must have been told by a lot of speakers about the metabolically obese diabetes. A lot of obesity molecules are coming up and they are going to sell themselves to obese as well as to non-obese people also. And they are saying that even if your weight is not higher, you are metabolically obese, so you should also take this molecule. And importance is the high smoking and alcohol consumption, refined carbohydrate rich diet, and reduced physical activity. So if we come over to this pyramidal presentation of risk factors which are specific to the rural India. Here you can see in rural India what is the biggest factor, that is socio-economic factors. Physical inactivity, changing dietary pattern, genetic predisposition are not that much important for the rural India, but socio-economic factors is making a bigger base in the rural population. It has also been seen in a study, if we combine the genetic inclination with the socio-economic risk factors, then 7-folded increase in the type 2 diabetes and 3-folded increase in the obesity could be registered. So socio-economic status is having a lot of importance because genetic predisposition is the same for the urban and rural both. Genetic predisposition is not going to be changed. Even it is not been changed in last 50 years, is not going to change most likely in next 50 years also if any nuclear bomb etc. may not come up. Additional risk factors, tobacco, alcohol, we all. So once we talk about the diabetes self-care essentials, all these things are to be struggled in an urban population. But in rural population, the things which are most struggled, the last two, medication adherence and blood sugar monitoring. These two things are really lacking in the rural population, They are very do in the healthy eating, very good, as better even the urban population in the healthy eating. They have got the good coping strategies. They cope the problems even better than the urban population. They have got the physical activity which may be much higher than the urban population, even if it is lesser than their earlier one. So managing diabetes requires ongoing adherence to the treatment and prevention of complications. And if we can really address these two things in the rural population, we can do really the wonder to tackle their diabetes and other non-communicable diseases also. Let's have a look over this graph. This gives you a rising prevalence of the diabetes in rural India as well as in urban India. The yellow one is of the urban India and dark orange one is the rural India. You will be surprised to see that rural India is just following the urban India. For example, in 1990, the prevalence was 5.5% in the urban India. But after 10 years, the rural India has got the same prevalence, 5.5%. Similarly, you can see when rural India was having the 5.5% prevalence, the urban India was having the 8.1. After 10 years, the rural India was having the almost same 9.1. Then you go further, 12.4 was the prevalence when this urban India was there, and 12.5. Here they are coming at the neck to neck. Now prevalence is coming to the closer. That widening gap is gradually coming to the very close. Multiple factors are there. If we go into the regional split, we can see that southern states shows the highest diabetes prevalence rates in India, with both urban and rural areas affected. But at the same time, we see that highest reported prevalence is in the northernmost state, that is the J&K. 26.5% prevalence in the urban areas we could register in Jammu and Kashmir, and 14.5% in rural areas according to recent ICMR India results. And 14.45% in rural India may be having with lot of hidden diabetes, because many of the people are not known and they have never got tested themselves that they are having the diabetes. It is lesser in the central and northeastern region. It's a good thing. We can appreciate that. Now, another problem, what I was talking about, the hidden crisis in the rural area. 36.7% of rural individuals with diabetes who remain undiagnosed as compared to the 22.8% in urban areas. Because lot of infrastructure deficit, never people go to check their blood glucose level, never they think that they may be having the diabetes or any lifestyle disease, so they remain reluctant to get checked their glucose level. 2.3 times higher risk having undiagnosed diabetes for rural residents compared to the urban counterpart. At the same time, biggest problem is that treatment gap. Rural participants were having the 2.3 times more likely to have untreated diabetes than their urban counterparts. And that is simply because of that. Today they have got the hyperglycemia, got some problem, went to doctor, started the treatment, and after 10 days or 15 days when they became normoglycemic, stopped the treatment. And this is the biggest reason for that. High proportion of the undiagnosed cases in poor glycemic control represents a major challenge in rural diabetes care. And this lack of diagnosis and control increases the risk of serious complications such as cardiovascular disease, kidney failure, neuropathy, blindness, lot of things are there, lot of complications we know about there. Nowadays our policy makers, our people, those who are sitting in the government, they become very happy when they establish a tertiary care hospital in some area. They donate 10 or 15 dialysis units and they donate cath lab, etc., etc. They become very happy. But if we can really address this problem at the primary health care level, address the problem at the village level where the problem is starting, probably we may not be requiring this much of the tertiary care units what they are really looking for, investing so much of the money. If the money is being invested at a tertiary care could be diverted, of some part of could be diverted to the primary health care, probably the situation could be changed. And that tertiary care could be utilized for the revenue generation by treating the people, those who are outside of the India having the complication. The national control rates, as per the National Family Health Survey, reported that only 7% of the individuals with diabetes in India have their condition under control, with rural populations having even lower treatment and control rates. No data is as of now confirmed about the rural population, how many people keep their glucose control at the rural population, but overall control is 7% or less than that. Now question arises, what are those socio-economic barriers for diabetes care which are leading to this 7% situation? Of course, the awareness gap. This awareness gap is much bigger between the urban as well as the rural population. Urban population is having the awareness of the 33.7%. It is also not up to the mark, despite RSSDI efforts, despite government efforts, despite so many other organizations, even like API, many other organizations, those who are not even directly working for diabetes, but they are working for the non-communicable diseases. They are fighting hard against the diabetes, but despite that, only 33.7% in urban population are aware of the facts about diabetes, against the 23.9% of the rural population. Gap is not that big as we were expecting that. Annual cost of the managing diabetes in India ranges between 8,000 to 46,000, creating significant financial strain for rural family. Why does this go to the 8,000 to the 46,000? Lot of compulsions remains there for the costly medicines to be sold out so that we can have the expenses and validity to be meted out for expending so much of the sponsorship and all that. And all these burdens comes to the prescriber's oneself. Prescriber has to face this burden. And that's why the same person who is getting treated in 8,000 rupees, another person is spending 46,000. Treatment disparity. Urban treatment rate 27.8% as compared to the rural treatment rate 17.7% highlights the unequal access to the diabetes care. Only 45.2% of the rural individuals with diabetes have access to adequate diabetes care compared to 68.5% in the urban India. States with the lower human development indices have higher proportion of the undiagnosed diabetes and poorer diabetes care, which may be the states like Chhattisgarh, Jharkhand, Bihar, where we face, and in Uttar Pradesh also, where we face the lower human development indices. Now, this is again a very interesting chart, and you would appreciate and you will be amazed to see that. In the poorest section of the society, 14% people are aware of the diabetes, 9.9% are taking the treatment, and 4.7% are getting control. Right. But in the richest section, this gap is so wide and such a big population, I think 3 times of the poorest population are aware of their diabetes, 37.3 are aware of that. And about 80% are taking the treatment. But the control is only in the 20% people. 9.1% people are having the control. So, who is doing the better? Obviously, the poor population is doing better. But the only problem is from our side. We are not making them aware of their problem. If this awareness 14.1% could be equal to the richest population, this 37.1%, probably their control rate would be much higher, and overall control rate of the country would be higher, which is 7%, may go up to the 14% or 20%. So limited healthcare infrastructure in rural areas, 80% percentage deficit in required community health centers in rural India. 31.4% of the rural sub-centers lacking proper infrastructure with no dedicated building. And the biggest challenge is that we are having 4,413 specialists. This is the number against the requirement of the 21,964. The requirement of the specialist is 21,964, but we are providing only 4,413. So this is the biggest gap which is to be filled up. So one of the biggest hurdles in rural diabetes care is limited access to the healthcare facilities, deficiencies in this healthcare facility, trained endocrinologists, diabetologists, diagnostic facilities in rural areas are not really reaching, and they are delaying the diagnosis and actually responsible for the treatment gap. Government is taking a lot of initiatives like screening and standard care initiative with the target at the 2025. This Ministry of the Health and Family Welfare aims to screen and provide standardized care for 75 million individuals with diabetes or hypertension by 2025. National program for the prevention and control of NCDs is also going on. Ayushman Bharat Health and Wellness Centers is also working with the target of screening individuals over 30 years for diabetes and other NCDs. Free medication and generic drug access has also been started to be made available to the people with the different name. In some places they are the Pradhan Mantri Aushadhi, some places they are the Jan Aushadhi, some places the state government is providing. Everywhere the things are being provided and medicines are being provided. Some people may say that at these places medicines are not up to the mark and they may not be of that quality, what the medicines could be of the quality when they are being branded with name. But once the things will keep going on, obviously a day will come when we shall be having the good quality medicines in these stores also. Once majority of the population will go there, up to how long the quality could be avoided to that places. Specialized Rural Diabetes Initiative. Rural Diabetes Prevention and Control campaign, which has been initiated in 2021. This campaign focuses specifically on diabetes prevention and control in rural areas, exemplified by its launch in the Purana Ramnagar village, Varanasi district. And this Purana Ramnagar village is the same village where the RSSDI has started its working at Varanasi. Chunampet Rural Diabetes Prevention Project. This project implements comprehensive diabetes screening, prevention and treatment using a combination of the telemedicine and personalized care in rural India. RSSDI Village Adoption Program, we are coming up with that Village Adoption Program, and probably in the coming years we shall be working with the same vision what I have just shown to you, with going to the villages and trying to fill up the gap between the specialist availability as well as people's awareness to be increased. How can this increasing awareness and education could be more and more? Obviously the community health problem, in the local language resourceful, and training the local health workers could be the option. And apart from that, there could be multiple other options like our trained physicians, those who are doing their very good practice in the cities, they can go for some time, 1 hour or 2 hours in a week or in a month, and they can handle the problems of the populations in the rural area. Expanding screening and early detection. Screening could be facilitated with the mobile screening camp. Point of care diagnosis, which is more popular in the cities, could be actually of use in the rural area, where the HbA1c testing kit operated by trained rural healthcare providers to enhance early detection without requiring sophisticated laboratory infrastructure of much value. Household screening program, which could be implemented with the door-to-door diabetes screening, particularly in high-risk rural communities, to reach individuals who may not proactively seek healthcare services. Region-specific approach. Essential resources for my primary healthcare, as we have already discussed, those resources could be more at the primary healthcare when we can available the reliable glucometer testing, basic laboratory facilities like HbA1c testing, consistent supply of the essential diabetes medications. But at the same time, what the gap could be filled by our efforts, and in which the RSSDI can play a big role, that is the telemedicine integration. If we can really connect with the doctor who is sitting at the primary health care, and he is connected with the person who is our expert who is sitting in the city or in the metro cities through the telemedicine, Dr. Jyoti Dev is doing for last 27 years. And I could know this when he has given his talk in the Springfield recently when I was with him during the ADA. And then I could know that what we are doing for last 4 or 5 years, he is doing for last 27 years. And with the excellent results. Promoting lifestyle intervention, culturally tailored diet counseling, physical activity program, engaging local influencers in the physical activity program as well as diet consultation also, and traditional practices which are hindering the people to take the appropriate lifestyle measures, take the appropriate treatment, is to be handled by those local influencers in the city or in the area or in the village. Culturally appropriate dietary recommendations which could be suitable to the local traditions and local people's taste and development, and they could be easily consumed by them. Improving medication access and affordability could be already being done by the government through the subsidies, could be more influenced, quality could be improved there, public-private partnership could be another option, and reliable supply chains could be improved there. Affordable access to diabetes medication and insulin is crucial for effective management. Government subsidies can significantly reduce the financial burden on rural population. So enhancing the monitoring and follow-up, that is the biggest need for the population who is residing in the rural population. It could be done by the mobile health, could be done by the telemedicine, could be done by the peer support groups. And integrating with the national program, incentivizing the healthcare workers, those who are working in villages, those who are going to the primary healthcare center, they could be given some more incentives for there. And of course, the data-driven approach is the most important. We should have sufficient amount of the data. Community engagement strategies are there which can be implemented for getting the good results. Technology-enabled solution in the form of the digital health records, in the form of the artificial intelligence assistant screening, and addressing the gender disparities in the diabetes care is one of the important thing what we can do at the village level also. And addressing diabetes in elderly and rural population like age-appropriate care, family support system, home-based care, they should all be facilitated for the elderly population. Integrating the traditional and modern medicine like evidence-based traditional practice, collaboration among the various care models is another thing which could help us in improving the picture of the diabetes suffering population. Urgent public health challenge, it is there, we can understand it very well. We can definitely know that what are our needs and what could be the strategies to handle those needs. And collective action is required to reach to address those needs. Thank you very much for your kind listening.
Thank you very much, sir. That was a wonderful presentation. We are running short of time, so we can take one small question from any of our audiences. It was a very nice presentation, sir, because personally I work in a rural setup, so it really reflected on me. And one of the things is that when a patency of a medicine gets over, I'm very happy because now it's more affordable for my patients. So, and awareness was a very important thing because sometimes just sitting there and explaining to them what is what makes a lot of difference. That's true.
Yeah, I really look forward to Dr. Anita Nambiar and other peoples of the state chapters of the RSSDI from Kerala to start at least 2-3 villages working with the RSSDI. Although Kerala is well-developed state, but still some sections would be there, those who may be needing a good support from the RSSDI, those who may be needing to monitor and implement the measurements to handle their diabetes better. And this can definitely make the changes. So we are here in the most developed state of the country, most literate state of the country, but still if we can do better here, the message will go whole of the country that this is to be done, and this is the model of doing that. Thank you very much.
Has 7 projects going internationally, India as well as international, and diabetes amongst the medical part of it, of Lions. There are 2 diseases they are laying stress on. One is diabetes, another is pediatric cancer. So I feel RCTI can tie up with Lions also, that way we can benefit.
Yes, really, I am really looking forward for all state chapters. You start in the West Bengal, and these people can start in the Kerala, and whole of the India will come up for the care of the rural population. Then the hidden diabetes would be handled better, and definitely this 7% figure will go much higher.
Yes,
As of now, India is having only 7% diabetes under the control, and we really need to make it at least 20% or 25% in next 5 years or 10 years.
Thank you,
Thank you.
dear Chairperson and Speaker, for the thought-provoking insights. As we near the end of the day, we dive into transforming diabetes care with next-generation basal insulin and fixed combinations. Let's welcome our chairpersons, Dr. Edwin George, Associate Professor of Internal Medicine at Amla Institute, Thrissur, and Dr. Arun Shankar, Medical Director, Jyotidev's Diabetes Hospital and Research Center, and Secretary, IMA NEMO.